Great. Hello, everyone, and welcome to today's ADEA Advocacy Insights. Thank you for joining us today. Our topic today will be Medicaid changes under the One Big Beautiful Bill Act. And we are very fortunate to be joined today by a guest speaker, Akeiisa Coleman. Some of you may have heard her speak previously in annual session. She did a great job describing some of the potential changes to Medicaid that could be coming under the Trump administration. And now that we have legislation passed and we know what those changes are going to be, we've invited her back and she graciously accepted to describe those changes, to talk about how some of those might look once they're implemented. Before I introduce Akeiisa, I want to let you all know that this webinar will be recorded and shared publicly on ADEA's YouTube channel and other digital platforms. By participating today, you consent to the recording and distribution of the event, which may include your image and comments if shared during the session. Akeiisa Coleman is a Senior Program Officer for Medicaid, Expanding Coverage and Access to the Commonwealth Fund. She's responsible for the Medicaid and state-facing grants. She advises on strategy around federal and state policy, contributing to fund research and publications, and helping to execute projects and events to inform and educate policymakers at the state and federal level. Prior to joining the Commonwealth Fund, Akeiisa was a senior policy analyst with the National Governors Association, where she managed multiple projects related to social determinants of health, Medicaid, and behavioral health. She also spent some time with the Missouri Foundation for Health, where she wrote and edited reports on the Affordable Care Act, Medicaid, Medicare, and health disparities, and also assisted in the development of grant programs and requests for proposals. One of the more interesting pieces of her background, I think, is that she actually had some time working as a clinician. While working full time at the Health Policy Association, she was also a clinical social worker at the Barnes Jewish Hospital in St. Louis from 2009 to 2015. Coleman earned an MSW from Washington University in St. Louis and a BA in sociology from the University of Southern California. And with that, I'll turn things over to Akeiisa.
Thanks, Phil. And hopefully this session will be informative. I know that there's a lot to cover. It's complicated. So please, drop questions into the chat. I will try not to use too many acronyms, to keep things clear. And let's dive in with some key Medicaid policies in the final passed reconciliation bill, which I'll be referring to as HR 1, also commonly referred to as OBBA or OB3. So I'm going to start with the work requirements because I think this is one of the really big pieces. It's also an area where folks may have some confusion. So it is a new national requirement for Medicaid enrollees in expansion group. So all 40 states plus the District of Columbia, as well as waiver programs expanding coverage in Georgia and Wisconsin will be subject to the work reporting requirement for adults ages 19 to 64, beginning effectively January 1, 2027. People have to work 80 hours a month or complete other qualifying activities, such as volunteering, participating in education or job training programs. There are a number of exemptions, including pregnant women, individuals with disabilities, parents with dependent children, parents with substance use or individuals with a substance use disorder or disabling mental health condition. One of the key things about the Medicaid work requirement is that it cannot be modified through 1115 waivers. That's the demonstration process that allows states to test different models of care and see if they can't improve health outcomes through innovations. The work requirement cannot be modified. And people who lose coverage due to the work requirement are not able to go to the marketplace to purchase coverage with financial help, the premium tax credits. So some of the anticipated impacts of the work requirement are that it's going to introduce new hurdles for Medicaid enrollees to get and maintain coverage. They have to show proof of employment at least 30 days, or that they're meeting those qualifying activities at least 30 days prior to their enrollment in Medicaid. It increases administrative costs for state Medicaid programs, including significant eligibility and enrollment system upgrades, as well as trying to capture additional data that states may not already have been collecting, and additional staff to oversee compliance. So sticking with the work requirement for a little bit, um, these are some of the things that are going to impact how the work requirement is implemented. One of those items is guidance from CMS, which is required by HR 1 to be issued by June 1st of 2026. That's about 6 months before the requirement takes effect, which means states are starting now to implement the work requirement, making adjustments to their eligibility and enrollment systems. That guidance may make the timing for that guidance or any pre-release of what direction CMS is going is going to be really critical for making sure that states can respond in a timely manner to meet the requirements from CMS, have their systems updated and functional before beneficiaries have to start utilizing those things and meeting those new requirements. So it's really complicated. There's a lot happening here, and it's going to be really tricky. Um, there are federal resources included in HR 1 to support implementation. $200 million in grants that are subject to the work requirement, which may seem helpful. However, that's going to be divided among 42 states plus the District of Columbia. And one analysis by the Government Accountability Office found that Georgia spent over $54 million on administration, and estimates for the earlier work requirement demonstrations during the first Trump administration range from $6 million in New Hampshire to $272 million in Kentucky. So the administrative costs for implementation are significant, and those federal resources may not go that far. Implementation is also going to vary from state to state depending on their approach and resources provided by their governor and state legislature. So whether or not that they have sufficient staff to oversee those modifications to the systems, to fully communicate what changes are happening and what the new requirements are for Medicaid enrollees, the managed care plans, community health centers, and other trusted voices that Medicaid enrollees rely on, as well as the state and county eligibility staff themselves who will, the number of folks who are going to be available to help Medicaid enrollees navigate these changes. Just as one example of what this potential cost could be, Arizona's Medicaid agency, Access, requested over $71 million for HR 1 implementation and estimates they'll need an additional 320 full-time equivalents to implement the work requirement and other HR 1 changes. So that includes modifications to the eligibility and enrollment system, systems for sharing data, and eligibility staff at both the Medicaid agency and the agency that actually does the enrollments themselves. That's through a different agency. So enhancing that agency's staffing to support the implementation of work requirements. There's a lot of pieces here. This is going to look very different from state to state, despite everyone having to meet the same requirements. So taking a look at Arkansas and Georgia and what we know about how the work requirement has played out in those states, Arkansas implemented their work requirement for 9 months between June of 2018 and March of 2019. Um, it's very similar to the requirements are similar to what was included in HR 1. Key things to note here, in the 9 months that the work requirement was in place, 18,000 people lost coverage due to the work requirement. Much of that was due to the reporting process. And notably, there were no increases in employment, and people who lost coverage, delayed care, skipped medications, and incurred medical debt. So this is just this chart just compares those who were continuously enrolled in Arkansas versus those who lost coverage in Arkansas. And then if we shift gears to Georgia, the work requirements demonstration in Georgia is called Pathways for Coverage. It was launched in July of 2023 and recently received a waiver to continue through December of 2026. At that time, it'll have to come into compliance with HR 1 if the state chooses to continue their kind of partial expansion. One of the things that is really significant about the Georgia work requirement, they require verification upon enrollment in the program that you are meeting those community engagement activities, those work requirement engagement activities. So that's one of the key features of the work requirement in HR 1. And in the first 12 months of the work requirement in Georgia Pathways program, less than 5,000 people were able to gain coverage. And the administrative processes were a major factor. After 2 full years of the program, just over 8,000 people had enrolled. As of October 31st of this year, there are just under 11,000 people enrolled in Pathways to Coverage. So the enrollment has been underwhelming. It has had really high administrative costs. In the first year, it averaged about $13,360, $13,360 per enrollee. The majority of that was spent on administrative costs, not healthcare. So really expensive, and less than a quarter of spending has been on healthcare benefits. So this is just a snapshot of the eligibility determinations for the first 2 years of Pathways. 1 out of 10 applications were denied for failing to meet the qualifying activities and hours requirement. And at renewal, 2/3 of people lost coverage because for whatever reason, they didn't return their renewal packet. So it is really difficult to enroll in Pathways to Coverage. And the majority of people just weren't able to stay enrolled in the program and were not clear why. So there are a lot of issues with Pathways to Coverage, which really is the model for the work requirement in HR 1. really telling about the Georgia experience in their Medicaid 1115 renewal application. They modified their waiver to ease some of that administrative burden for enrollees to make it easier for them to enroll and stay covered. Those modifications will not be allowed under HR 1. So there's a lot of questions about how challenging the work requirement is going to be for people to navigate. Shifting gears and looking at some of the other provisions the in HR 1, there are more frequent eligibility checks for those in the expansion group. So every 6 months, starting in 2027, people will have their coverage redetermined every 6 months. So again, we're creating new hurdles for expansion enrollees to maintain coverage, increasing costs to administer the state Medicaid program, as most likely states will need to have additional staff to oversee compliance and process applications when people re-enroll. We know that providing uninterrupted Medicaid coverage for at least 12 months significantly reduces churn, which in turn reduces states' administrative burden and administrative costs for both the state and patients. So 1 in 10 Medicaid enrollees lose and regain coverage within 12 months. This is stepping away from under the Biden administration. There had been a move towards more 12-month continuous eligibility for different populations and multi-year continuous eligibility for children. This administration is significantly stepping away from that, and HR 1 is reinforcing that. There is also a new cost-sharing requirement for the expansion group. States must impose cost sharing for the expansion group for those individuals in the expansion group with income above the federal poverty level starting in October of 2028. Cost sharing cannot exceed $35 for any service, or the standing statutory rule of 5% of family income. And providers can deny service for failure to pay any copays required at the time of service. Again, we're adding hurdles for the Medicaid expansion group, impacting their access to care. Because it can be difficult to calculate family income or household income with income variations, whether that's people who are working hourly and their hours are shifting, or people who have seasonal employment and their income significantly fluctuates over the course of the year. So they may wind up paying more than that 5%, more than 5% of their income through all of those cost sharing that they may experience over the course of the year. And enrollees may avoid care because they don't feel like they can come up with the money for any copays that may be required at the time of service, which will likely result in increased emergency department utilization. And again, this increases costs to administer the state Medicaid program, as states have to figure out how to track and determine what people's cost sharing should be. In an Oregon experience with premiums and copays in 2003 for adults with income up to 100% of FPL found that nearly 2/3 of individuals lost their coverage as a direct result of increased premiums and cost sharing, and those who left the program because of the cost sharing reported worse access to care, less primary care utilization, more emergency department utilization, and greater financial hardships than those who stayed enrolled. And so we have some documentation about the impacts of both premiums and cost sharing arrangements in the Medicaid population, and know that there are significant challenges to this. There is also a new moratorium on provider taxes. I'm sure many of you have heard about this. This impacts how state and local governments can contribute to the state share of Medicaid. They are not allowed to implement any new provider taxes or increase the rate of provider taxes already established as of the signing of HR 1. Provider tax rates are frozen at the current levels they had in place before the signing of HR 1, and expansion states have to meet a lower safe harbor threshold for provider taxes by 2032. So the current safe harbor threshold is 6%. It will stay that for non-expansion states. For the expansion states, they have to step down their provider taxes to 3.5%, by a 0.5% a year starting in, I believe it's 2028. So this has significant implications for how states fund their share of the Medicaid program and makes it harder for states to raise revenue to cover their share of Medicaid costs, which is pretty significant. At least 22 states will have to reduce their Medicaid or their provider taxes on hospitals and managed care organizations. We know that there are provider taxes on other types of providers that may also have to come down. So there's a larger number of states that are likely impacted by this than are shown in this particular map. I know I'm covering a lot of ground, but bear with me. I'm going to shift gears and talk a little bit about how states are starting to respond to the law. There are a handful of states that are looking to start implementing some of the provisions in the law early. So there are 2 states that have indicated that they want to implement elements of cost sharing early. New Hampshire has legislation authorizing the Medicaid agency to implement premiums. Montana has also submitted an 1115 waiver to implement premiums and plans to seek a waiver to do premiums in place of copays, because they have a state law on the books that prohibits them from collecting copays or implementing copays as specified under HR 1. We might also see early implementation of work requirements. There are 7 states that have pending 1115 waivers. Only one of them, Utah, has said they will not implement work requirements before the HR 1 deadline. So we're still keeping an eye out on this. It is a heavy lift to implement work requirements, as we saw during the first Trump administration and with the Georgia Pathways waiver. So it will be really interesting to see if any of these states actually attempt to implement work requirements early. Before I get into the next piece, I just want to remind folks that states have limited levers for addressing a shortfall in their Medicaid budget. So those are raising revenue, reducing eligibility, or reducing optional benefits, or reducing provider payments. Some of those optional benefits include dental services and dentures for adults. and things that are really important, like prescription drugs that may not make sense to cut. That said, here are some of the early state responses that we've seen um, with North Carolina, Idaho, and Colorado reducing Medicaid provider payment rates. So these are kind of across the board cuts for all providers, for all provider types in the states, with some deeper cuts for different services or different provider types. Colorado is also capping its dental benefit for adults. Given that home and community-based services are a major cost in Medicaid, a number of experts anticipate we'll see more caps on who is eligible for home and community-based services, along with longer wait lists for those services. And those facilities that are impacted by some of those provider cuts, like nursing homes in Idaho, may not be able to continue to operate with the lower Medicaid reimbursement rate and close, further exacerbating some of the health disparities that we see across the country. With that said, I know I've covered a whole lot, so I'm gonna stop for questions. I have a bunch of resources for you that will be included in the slides that are shared afterwards. But happy to take questions now and help clarify anything that I've covered or things that I didn't cover.
Thank you so much, Akeiisa. If you could please use the hand raise emoji or function when your hand goes up, we'll call on you just to try to keep things orderly.
No questions. I covered everything
Thanks.
perfectly, clearly.
Yeah, it looks like it. It looks like it. Uh,
That's a first.
yeah, yeah. Um, I think one question I had, would you be able to describe kind of the way the provider taxes work
Sure.
uh,
Um,
and how they increase revenue for states?
yeah, so um provider taxes are supposed to be uniform, broad-based, and apply to an entire class of providers. So the hold harmless provision says that states collecting taxes, so that taxes below that threshold, the current 6% threshold, um, are sorry. So there's the hold harmless provision that effectively says that taxes paid by the provider type um, are not guaranteed to be reimbursed to the provider through Medicaid reimbursement. So um, the when you have taxes below that threshold, that 6% threshold, you don't necessarily have to follow all of those rules. Um, and um, the taxes on providers are squishy, right? So these providers can say we'll contribute or we're paying X amount to the state for our provider tax. The federal government is going to match that at whatever the FMAP is, whether that's a regular FMAP of 50% plus 90% for the expansion group. And that in turn results in reimbursement for the provider. Um, the states can take an additional step to raise reimbursement rates through state-directed payments. which can have been used to raise reimbursement rates above Medicare rates to the average commercial rate in that area. There are new restrictions on state-directed payments, which is why we often talk about provider taxes and state-directed payments in the same conversation because they are related in that the provider tax helps to pay for those state-directed payments. Um, but the new restrictions on state-directed payments treat expansion and non-expansion states differently, where non-expansion states can have state-directed payments that bring rates slightly above Medicare rates to 110% of Medicare, and expansion states are capped at Medicare rates. Um, I know all of this is super complicated and really in the weeds, wonky stuff, but there are concerns that between the provider taxes and the state-directed payments, um, providers are coming out ahead, and that they're getting back more in Medicaid reimbursement than they are contributing through the taxes. Um, and that it's kind of um, there are concerns that it is not those contributions through provider taxes don't really appear, or that they may not actually be paid to the state, and the hospitals are just putting those dollar figures on the books in
Mm,
order for the state to collect to draw down additional federal dollars.
okay, thank you. Um, one last chance to see if there are any questions. Well, seeing none, thank you all for joining us today, and thank you, Akeiisa. We really appreciate all this wonderful information that you've given us. I know this is a complicated topic with a lot of different areas, and we appreciate you covering all of this so succinctly and providing us with all this new knowledge today. So thank you, and thank you all for joining us, and I'll give you some of your day back. Bye.
Right. Happy to be helpful.